urgent care and yeah, we're not gonna go through it, we're just talking a little bit about it.
Okay, here's some pictures. Then this one.
How far around are our handouts so far?
There's your Alicia.
They take forever usually. No.
Thank you.
Look where I hold on to. It didn't hurt him.
You know how annoying that's so annoying.
Whatever you think. You gotta put on the two ring binder thing.
Oh my goodness. What's all like?
Wasn't that nice of him to punch holes in our papers for us?
Sure.
Did you see my face on
I'm y'all's handyman.
I'm just ready to go home.
What are you doing? They're hoping you take some so we don't get them?
She's probably got the camera turned right down. That's like a sting operation. Makes you smell, I know that.
We have to move it to a traditional.
There you go.
One side, one side.
What, the Florida?
And you put it in your.
Usually not, just kind of a basic understanding. Probably, and we'll do more of that in rehab, but that 1 inch to 12 inches of ramp is a real.
You like holes punched in the bottom of your paper?
So 1 inch of ramp is 12 inches.
Let me punch your-
1 inch height of ramp is 12 inches.
If you're tired, I'll go do it.
So every inch you go up, you try to do 12 inches of ramp. So if you're at 20 inches, then you have to put a new ramp. And that's ideal, it can't always happen, but that's the ideal height. That's the
Boy. It's all out.
questions they ask on
Paul can't bring the anchors around.
One of the things that I left out on both the hip and the knee is after you've been in with them for a time, the hypersensitive, you need to always check, if your PT missed it, you need to always check for hypersensitivity around the scar. And it's real common for me to get one after they maybe have been in rehab 6 or 7 weeks down, who are still having pretty severe pain in the hip. And if I do a little desensitization of the scar and maybe use some kinesio tape on it, I use kinesio tape a lot for desensitization around scars, by the way. And usually where they're sensitive will be at the ends of the scar. I have a lady right now in Red Oak, and she's about 2.5 months out now, and she is extremely sensitive. We're doing some really deep massage with her, and you can feel that. Last time I saw her, I broke something up. I felt it break, scared me. So I called her actually 2 days after, kept calling her to make sure she was okay, but she's so much better since we did that. And so I did that, and then I put just kinesio tape over it. So I'm gonna go see her today and see how she's doing. But many times, and we talked about on the hand, how hypersensitivity around the scar is such a big deal. It is also a big deal on a knee and a hip, so make sure you test them. And when you test them, you don't just do, oh, tolerate a thumb all the way up and down that, and if they can't, they need you to do some massage. You need some deep pressure massage in that area, because you don't want that to be sensitive, okay?
How does that
So-
even work? I mean, how does that?
Some people just are more hypersensitive around scars than others. Sometimes, and especially, where you usually see it again is at the very ends of the scar. Some people never have any hypersensitivity. So it just depends on the person. It's just the way they're made.
How
and
would
they-
you test them for that?
If they have pain in there when you're pushing down on that scar area, they're hypersensitive. If they're 6 weeks out, they should no longer have pain in the scar, over the surgical area.
That's what I was going to do when we have to do that in class and a presentation in front of
Uh-huh.
the,
You're gonna do it
in-service.
Uh-huh.
That's
That'd
what
be
I was
great.
going to do.
That'd be great, yeah. Because I'm gonna tell you, a lot of people miss that. And the problem, by the way, everybody listening to me? The problem, by the way, when you get into outpatient, is sometimes you quit touching people. So you need to make sure that you continue to touch your patient and put your hands on them. If you're not feeling around that area of pain, you have no idea what's going on there. If you don't put your hand on a back patient that's had back surgery and this is where they're hurting, that's why doing massage sometimes is such a good thing, because you truly, nothing like getting a neck patient that tells you that they're a 10 out of 10. They have full range of motion and not a spasm at all in their neck or in their upper trap. Those people are faking. I'm just telling you, they are. So, if you don't put your hands on those patients, then you don't know. So, I'm not talking about a brand new incision area. I'm talking 6 to 8 weeks out. They should not have pain around the incision area. And sometimes you deal with also, especially if the patient fell and broke their hip, you've got some soft tissue injury there. So you're not just dealing with a surgery. So you need to do some massage around that hip and get that relaxed and try and bring healing to that. So some of that is soft tissue and not just the incision with the hip. So if you don't, again, put your hands on that patient, you don't know that. So that's what's gonna make you a good therapist. I'm just gonna tell you, when you quit touching people, it really makes a difference. You really have to touch your patients. I touch every one of them. Just keep that in mind.
Yesterday when we pre-modded that lady, that's how Bill had me palpate and found her sensitive area, so we knew how to put the pads on.
Okay.
I thought that was pretty neat.
So you put that pre-mod right on top of the source, like the motor point. Remember, some of you, we were talking about, a lot of times, has Bill talked about motor points with y'all at all? What a motor point is where the nerve actually innervates the muscle, and a lot of times that's where your point of pain will be. That's where you'll have the, like if someone goes down, and it's called a trigger point, and especially in your neck area, there are very common areas that are trigger points, especially right here.
That's where
Correct.
she was.
And,
She was jerked when you
yeah,
palpated.
and a lot of them in the front part of their neck right here, these, right in this area, there's some really hard trigger points. So don't forget to work with the front also. When you do those stretches for the neck, make sure you do that one where they hold on to the side of the chair and stretch the front part of their neck also.
You know, when you're massaging somebody's neck and you feel the knots,
Uh-huh.
is that like?
That's kind of trigger points.
That's kind of true.
Yeah, and if you can work that out, that's good, if you can work the knots out. But it'll be a more sore point. And some people are so sensitive that they're gonna jump when you hit that trigger point. And y'all have, common places that people have soreness, especially right up in this area. Right up through the edge of the scapula. Those are real common trigger points that go down into the rib areas. There's one right here. You can find, there's one right here behind the, put your hands back there and find that little spot that'll almost make you jump. It's a nerve
I
pain.
can't do it.
Yeah, it's a nerve pain.
I can do one at a time. I can do one at a time.
Jim, I can't do it either.
That's okay, I can get to my side.
It's because you got short arms. Because Jim's got short arms.
No,
Oh, Blake and his T-Rex arms.
But anyway, those are trigger points, but you also have trigger points in the bicep.
Oh, yeah.
And it's usually right in here. But you can find those trigger points, and that usually will be the point of pain. One of the things that we did with some of the guys is learning how to find a place to put a TENS. using putting your finger on, and so have Bill show you how to do that one.
That's what he showed the FDA, the pre-mod.
Okay, he showed you, with the pre-mod, that's kinda what he did. Did he become part of the circuit and
Oh, no, he
put
didn't
some
do
stuff
that.
on his finger?
No, we never did that.
No, we never did that.
We'll have to do that. We'll do that on Monday.
How do you,
Fantastic.
how do you put kinesio tape? You just put the kinesio tape right over the spot?
Because of where her pain is actually, like about 3 inches right in the middle of her scar, which is unusual, and she did fall and break her hip. So I think it's more a soft tissue injury, more so even than a hypersensitivity. But what I did is I went all the way up and down her scar, and just laid it down for pain mainly. And
So it
just
kinda
the
lifted
whole
up the
scar.
skin over the scar?
Yes, yeah.
Okay.
And when I talked to her, she told me she was better, but she still has pain, so it dropped her pain level about 2 points. And she's like at a 6, and this is a lady who's had a stroke before, and she's tough. She's a tough lady, so if we can get that pain level down, that's all she's a normal strength on her hip, that's how much she's worked it. She's been in therapy for about 2.5, well, more than that now, about 3 months, and she's got normal strength in that hip, and that's all her stroke side. So,
Wow.
yeah, she had a stroke
So-
about 12 years ago.
I got a question, like if you don't do that desensitization with it, does that, don't laugh too much. Does that ever go away, or
It won't go away until they actually do that, and it's so
Okay.
simple to desensitize. But they'll have that pain in the hip maybe for years and years. And you can still do it 10 years later and get rid of it. It's just kind of a weird deal.
Is hers hurting so bad now that you can't do that? Or-
No, I really did some deep
Oh, yeah.
Massage into that hip, and I'm gonna go back and do it again. But as I was going over that, I literally felt something break in there. So I'm assuming that was like an adhesion in that area right up underneath that scar. It scared me because I thought, what in the world have I done, But
did you tell her that, or you just act like?
I said, are you okay? She never reacted. She felt it, but it didn't cause her more pain. And then at the end with the kinesio tape on, she was better. She felt better immediately. But when I talked with, I thought maybe it would actually get rid of all of her pain, because I thought maybe that was that. But she told me she still has some pain, but she's better. So I'm gonna go see her today.
So she gonna think you're a miracle worker?
I want her to. No, she doesn't.
Did you heat that or something before you did it?
The kinesio? I
No,
didn't.
the hip, did you put it out?
But that would be a good idea. I just didn't have anything to heat it with.
Okay.
I mean, she probably had a heating pad, but I didn't ask her for it.
Did you put a stretch on the kinesio tape?
I always stretch mine out at least 50% because I think that activates it. But, so I stretched mine out and then I put it back and just laid it down. So it probably had about 25% on it. Okay. Back to FIMS. I'm not doing all of this stuff with you. I just want to look at a few of them so you'll be aware of it. Just to give you an idea of the eating, this would probably be occupational therapy, but notice that a FM6 would also be dentures. Any type of modified diet because of chewing or swallowing, built up utensils, so sometimes your utensils for patients will have a big end on them so that they can have a better hold. Thickening agent, are y'all familiar with that, where you have to thicken coffee? It's horrible. Plate guard, anything that's an
Why
assistive
would you
device,
have to do that?
because they can't swallow regular fluids.
Yeah, you should see someone eat their water like pudding. It's awful.
It's awful.
And they hate it too, they don't like it.
You got
They were
some of that?
complaining big time at the nursing home.
Yeah,
This old guy was so thirsty, he said, do I have to put that stuff in there?
So that's something I got to look forward to, huh?
you'll learn about thickening. So remember on supervision, you're not touching the patient, but you're doing setup for them, so it may be opening up their food, putting the plate in front of them, that kind of thing. These are just some different things. I do want you to read through these, but we're not going through all this. Notice total dependent, you feed each bite, patient does not help at all. If they are hydration or nutrition given by the nurse anytime during 24 hours, one thing that's interesting is if they're doing tube feeding and they're doing it independently, then they're up here on probably a modified independent.
What do you mean doing it independently?
they are doing tube feeding as they are putting attaching it and turning it on. There are all those people who have to eat that way. So, but we don't see them very often, do we?
It's not that they could do that independently,
Yeah.
usually it's.
They'd have to set it, someone who needed tube feeding but was very mobile, you could do that. Normally, that's not the case. Normally, those type people require a lot of assistance. But you do have those people that have issues with their stomach, or all their intestines have been taken out, or maybe a child that had, what's it called, the trichinosis, whatever, where the intestines are on the outside of the body. Anyway, not good.
A real friend of intestine that's having money.
Kinda like a
Well, it's a
swallow.
common thing for little babies to be born with that, it's not. Okay, then, so we're not gonna look at eating, I just thought it would, I thought it would be nice to look at grooming though. Now, who does the grooming?
They do.
That would be an OT.
Oh, well, they both
As
are
far,
on there.
oral care, hair grooming, wash, rinse, dry hands, dry face, wash, rinse, and dry their face, shave face, or apply makeup. Let me tell you what, one of my patients told me the other day. He's a home health guy, and he was telling me that there was some man that came into his hospital room and didn't say anything to him and started messing with his hair and making him, actually took his hand and did all, it was some male OT that never told him what he was doing. And he told me that at the end of it, he finally figured out that he was evaluating him to be able to put his clothes on, but he never talked to him. He was angry, and I said, you need to complain about that. I told him that, so that, because remember, they're sending out all these eval forms now for people to tell their experience, because your hospitals are fixing to be paid by patient satisfaction, and you can now see this on the internet, so be aware of those things.
Well, that's kind of a good thing though, isn't it?
Kind of, but sometimes.
Except when you get that one person that's never had.
Never had, well, that's
Yeah.
Not one.
But it will make much better, I think people will work more at making people happy. You think we would want to do that anyway, but we're not seeing that much in the medical. We're seeing some real nastiness come out of some nurses and things, and hopefully not any therapists, right? Although that OT doing that was very inappropriate. Not good. Here's some grooming things, different assistive devices.
You need to sit him down and just start combing his hair and all that stuff without saying nothing.
Yeah, it was kind of weird.
Just hold him down.
Well, and what would have happened if he started hitting
Hey, guys.
and doing, then they would have said he had problems.
Don't ever buy you women
I do find that a lot of
Their oven's
even
got a clock
dementia
on it.
patients, if they don't know what's going on, they're gonna hit out because it make me mad.
Yeah, that'd make anybody, I'd be like, what?
So here's your bathing. So dressing, just, y'all read through these.
I'm trying, but don't.
Dressing lower body includes dressing and undressing from the waist down, as well as applying and removing a prosthesis or orthosis when applicable. Assess the steps that are performed. So you have certain steps that you teach them to dress. There's a certain way to put on a shirt with one arm and that kind of thing. And that, if you get an opportunity to work with some occupational therapists, take the time to go in and help them do a bath. It's very interesting to watch what they do, but that's like a 6:30 deal. So if you're in a rehab setting though, and if you can spend some time with the OT, that would be great.
How would you ask that? Because if I said, yeah, I want to help you give that old lady a bath, he might think I'm creepy.
Well, you wouldn't ask it that way. You'd say, I
No,
really would like
I
to
wouldn't. I just-
observe what you're doing and how you do the steps, and
Okay.
could I come in at 6:30 with you for that patient?
Okay.
And she would have to ask the patient, of course, but, and it could be your little old lady won't let you do that. And that's
Right.
fine, that's fine.
I just wondered how you'd ask to not come across as the creepy, because I wouldn't want
Well,
to come that way.
I don't think people are gonna take you that way, in a therapeutic setting,
Right.
so just make sure you stay as completely professional
Okay.
in your, in how you handle things.
Well, if you were the OT, you should go up to the patient and say, look, I would like, ask if it's okay to even bring somebody in the room.
Right, you'd have to ask the patient, and,
It would be good, because then you could see, like if you did home health later, what your patient was gonna have to do to be functioning on their own and stuff.
Mhm.
So
Yeah.
you could work with, I don't mean help them with that at home, but you know what they had to be. Does that make
right,
sense?
yeah, what kind of assistance they need,
Right.
yeah. Toileting is also OT.
Jerry, I was gonna ask you about like, you told us that we need to let people know, like, when we're taking, like, their vitals and stuff.
Uh-huh.
It's okay to tell them even if it's really not.
I would certainly go tell the nurse, but I would just kind of say, I'll be right back, you know, if it's really high. I wouldn't want to tell them if it's gonna concern them, yeah. My purpose in that is to educate, so that they'll know that 120/80 is good. And when someone tells them that their blood pressure's 80/60, that's bad, you know? So I want them to kind of start being educated in what the norms are. That's my thought on that. So no, if I was gonna concern them, you know, I wouldn't tell them. One of the things on going to the bathroom, by the way, is in toileting, they have to be able to take their pants down, sit down, take care of themselves once they're finished, and pull their pants up. So that is part of the toileting part. So just so you know that. Bowel and bladder is normally taken care of by the nursing. And so if you'll just read through some of that, we don't have to spend a lot of time on it. I'm gonna get down to, I just want you to realize what all was involved with this thing. That's all 12 of them. Transfers, here we go. Transfers, bed chair and wheelchair. This item includes all aspects of transferring to and from a bed, chair, and wheelchair, or coming to a standing position if walking is a typical mode of locomotion. So getting up and standing is part of the transfer. Equipment assisted devices. This is a FIMS 6 modified independent. Sliding board would be some equipment, grab bars, any kind of special seating, if they need a prosthesis, brace, anything like that. And then a mechanical lift would also be, of course, you're not gonna do a modified independent with a mechanical lift. Preparing for the transfer, film 5 would be placing the wheelchair at the right angle, possibly locking the brakes if they can't do that. So when you get into training them, a wheelchair patient, and they're gonna, let's talk about maybe a spinal cord, part of training is teaching them how to take care of the wheelchair parts. So make sure you do that. Removing armrest, handing the patient the sliding board would be a 5. Any of that stuff, you're not touching them when they do the transfer, but you're helping them set up, and you're not quite comfortable with them doing it on their own, so you're gonna supervise, okay? What if they have dementia and you're concerned about safety? Would you put them at a 5 even though they're completely independent at doing it? Yeah, you would, because safety-wise, if you're worried about them doing something, you know, and you feel like they have to be supervised to get it done, then that would be a 5, even though they're physically able to do all of it. And sometimes you just have to give them the steps of it if you're looking at dementia. Saying, okay, you need to get up from the chair, and let's come over and sit on the bed, and you want to reach back, and that kind of stuff. Transfers, part of the transfers is also getting in and out of bed, okay? So the transfer is standing up, turning around, sitting down on the bed, laying down, and getting back up. So that's the transfer. One limb only is a level 4. If it's the 2 limbs, then they need to be a level 3. So if you have to help them lift the limbs, then that's how that's divided. A lot of times your hips and knee patients are a level 4 at a transfer and you're going to document why. They may be completely independent in the transfer, but they can't get in and out of bed. I'm going to tell you this, I'm going to probably give y'all some of my soapboxes because I want you to be a wonderful PTA when you get out. But I recently, this same lady who's such a go-getter and was walking with a walker all over the place, had been in skilled nursing for 6 weeks. And when she got home, her husband was putting her to bed and back to bed because she could not lift her leg. How long do you think it took us to teach her to do that? 1 session. So that meant that you were in a setting where you were only working with them in the gym. You have to put them, at least and be aware that for them to be able to get up and down on a mat like we have in there is very different than getting up and down on a bed. So when you actually test this film score, you need to go and put them to bed, right? They really should be able to pull their covers up. In my opinion, that's part of bed, you know, for them to transfer. So just be aware that I'm guessing they gave her her a 6 on transfers on the FIMS score, but she could not lift her bed. And when you're dealing with a caregiver, and you're dealing with a little old lady that's gotta go to the bathroom 3 or 4 times at night, he's not getting any sleep. So if we didn't fix that problem, this guy's a rancher, he's like 75 years old, and he does a whole ranch up there. And, and he doesn't have, I mean, if she can get in and out of bed by herself, they had a bedside commode there, which she probably didn't need either, but they did have a bedside commode. Then, I mean, that made a big difference for them. You gotta take care of your caregivers. So I'm just telling you that a therapist dropped the ball with her. You see what I'm saying? And probably did not document completely correctly. They should have checked her getting in and out of bed. So what I'm finding in some of these gym clinics with assisted living is they're not doing leg exercises in supine. I do leg exercises in supine for all my hips and knees the whole time I have them. I don't quit doing supine stuff. They need to be able to get in and out of bed. So just because they're able to, you know, it's just real convenient to do them in the wheelchair, you better get them on the bed. It's very different to do a straight leg raise on the bed than to sit here and do this, right? And out to the side. It's very different when they're laying flat. Well, they have to function in that position, so you need to work them in supine. So that's one of my pet peeves.
Okay, so before they're discharged, do they look at the individual aspects of the FIM score or just the total as a whole?
They look, well, your physical therapy person looks at these 3 individual parts of a FIM score.
Well, like, cause like that lady got discharged and she
Right.
obviously wasn't,
She was
where
not
she
modified
needed to be.
independent. I'm guessing she was marked at a 6 though. They just assumed she could do that because she was so good. This woman was walking all the way up and down the hall.
okay.
But someone was still helping her put her leg in bed, and the PT or PTA might not have known. And maybe she was, what I'm saying is there was no reason for her to be a 4 on getting that leg in and out of the bed. I'm guessing they just didn't work her in supine, and I see that a lot. I'm just telling you, this is not just one patient. I see that a lot coming from rehab. I see that a lot coming from skilled nursing, is that they're not working them in supine enough. So you need to go with your patient some and work them in their room. They need to be able to do straight leg raises. They need to be able to do bridges. You need to see if they can roll on the bed. Rolling on the mat is, you want to start them on the mat, but that's a lot easier to roll on a real firm surface versus rolling them in the bed, okay? Assist to stand or sit, level 3. Assist to both sit and stand would be a level 2. So they define these even more. A lot of times you have to help them up, but you don't have to have them sit down. But if they're plopping, are you deemed to help them sit down more? Yeah, no, you don't want them to plop. Get rid of those plopping.
Off the dot.
Yeah, we don't want a broken hip.
Break that issue.
Total assist, major effort on the part of one person to lift, pivot, seat, and position the patient or 2 people, remember as always. If they are on a mechanical lift or a rolling shower chair, then they're a 1. So that's a total. Transfers to the toilet, equipment assistive devices, and actually commonly require bedside commode, elevated toilet seat, grab bar, so that would be a 6. So your tub shower transfer, I think really goes, but it's on here now, so I don't know, that would be a change. We'll just have, y'all have to ask when you get to, if the tub shower transfer now belongs to the PT person. Because normally that goes with the bathing part, so that would be new. So there's all the way that you would do that, and then you would put your level in there. Locomotion. Score the mode of locomotion the patient is expected to do at discharge. So if you're expecting them to be in a wheelchair, who would those patients be? Your wheelchair bound, your strokes that have been in a chair for a long time, spinal cord injuries, any of those who you really expect to be in a wheelchair. So basically you're gonna, to test them in a wheelchair, even though you might walk them little short distances, you have some people that have fallen so much that they don't ever want to walk again by themselves. So that's not a functional goal for them. It's a great goal if you have someone who wants to exercise them, but that's not a functional goal. Okay, now this is important on the locomotion. If they can walk less than 50 feet, then they have a 1. So everything below 50 feet is a 1 or less, hundred and 49 feet, helper needed, score the patient a 2 if they need any type of assistance from another person.
All
This
these are
in-
helper needed?
If you have a helper needed, what now? If you, it's 5 and below is a helper.
Oh.
But remember that they say no helper unsupervised in that you're not touching them. So the 5 is supervised, you have to be there, but you're not touching them. Isn't that the way that's set up? It said no helper on a 5, isn't that what you told me? But it's kind of, you really are have to be there for them. Score the patient a 2 if they need any type of assistance from another person. This includes supervision and cues for safety. No helper needed, score the patient a 5. So these are people who are not up to 150 feet yet. So if they're a 50 to 149 feet, they're gonna be a 2 if they need any assistance, but they're still pretty limited in their distance. This is looking at distance with locomotion. So you're gonna score them down even though they may not need any assistance. Who would this really affect? COPDers. They're limited to 10 feet. So they'd be a 1 even though they're completely independent in that 10 feet. They get up, they walk down the hall, and they come back and they do their 20 feet, but they can't go far enough, so they're a 1, right? If it's less than 50
Would you
feet.
put that independent up to 20 feet, something like that?
You wouldn't put it on your film score, because remember your film score, you would document it in your notes.
Like in your.
Yeah, but your film score would still be a 1 or a 2, depending on how many feet they have gone. On the 50 to 149, if no helper is needed, then they're a 5, and these are called a household exception score. If they do not need any assistance of any type from another person, they may use an assistive device such as a handrail, walker, cane, or wheelchair. And this is kind of a household ambulator. They can get up to 100, but they can't go any farther than that. 150 feet or greater, score a 3 if the patient requires mod physical assist. Remember, men is only, and this is greater than 150 feet. Remember that minimal assist is just balance. It's not helping them lift or really hold them tightly. If they start to really fall, that's a mod. But if you just feel like you have to be there for balance and might, help them a little bit, that's a min. Which would be a 4. A 5 would be if you're just cueing them, or if you do a setup. 6 is if the patient is independent with an assistive device, and 7 is independent without an assistive device. Then on your stairs down there, less than 4 steps, you have a score of 1. What they score it on, normally this is considered 4 to 6 steps, but they score it on a full, I think it's 15 steps, so a full flight of stairs. Which is sometimes hard to score it because you don't have a flight of stairs in your place. Less than 4 steps is a score of 1. 4 to 11 steps, I guess it's 12 steps. What's this, 12 to
So
14?
we're talking about stairs, these steps.
Yeah, stairs. 4 to 11 steps with a helper needed. Score a 2 if the patient needs any type of assist from another person, because you're below your 12 steps. This includes supervision or cues for safety. And then if no helper is needed, a score of 5. If they do not need any assistance from another person, this includes cues or supervision. They can use handrail or other assistive devices. And then 12 to 14 steps, it kind of goes into your 3 to 7. So just kind of look at that. Locomotion, walker, wheelchair includes walking once in a standing position or if using a wheelchair once in a seated position on a level surface. What mode does therapy expect this patient to do at discharge? How far can they go? Less than 50 feet score is a 1, 50 to a 149 is a 2 to a 5, 2 or a 5, and then greater than 150 can be the 3, 4, 5, 6, and 7. Less than 50 is always a 1. It doesn't matter how much or how little they need help. So they're always a 1 if they're less than 50 feet because that's non-functional. Score of a 2 on a 50 to a 149 regardless of patient needing any type of assist. Hands-on supervision or cues. 150 feet or more, you've got 3, 4, 5, 6, and 7. Helper puts effort into task. Helper touches for balance or correction. 5 would be cues, setup provided by helper. 6, patient is independent with the device, and 7 is independent. Okay, here's your stairs. Locomotion, stairs, number of stairs going up and down. How many steps? Less than 4, 4 to 6, or greater than 12. I believe 4 to 6 is considered household. Less than 4 steps, your score is always a 1. It doesn't matter how much help they need. 4 to 6, it can be a 2 or a 5. Patient needs any type of help from another person would be a 2. If they don't need any help and they can use an assistive device, and again, these 5s would be your COPDers that don't have balance issues, but they have distance issues. And then there's greater than 12. You won't be testing patients on stairs, but you may need to know the scoring for credentialing. I don't know why it says that. That must have been for Mercy, I don't know. Okay, so then they do cognition, so you might want to look at that. Communication, comprehensive, if you want to just get an idea, but I just want you to be aware of what all is on there, but those are the ones that, the 3 that we give are the ones you're looking at: transfers, gates, and then others. So here are some examples of patients I want you to grade, and you can certainly work on these together.
Me and my partner have a son.
Good partner, the guy behind
Oh,
you.
hey, there you go. He's a smart guy.
I'm not acting.
I know you do.
Has been here before our final, or?
Yes, we'll have one more before the final.
I don't really have to.
Yeah, we do.
Just you.
You don't want 3 tests, do you?
We don't want all the 3 tests. Unless it's a bad test. Those are-
What's a bad test?
Y'all got extra?
Always got a little extra.
We got a lot of extra. Thank you. You got a whole punch.
We have an extra. Have you guys got
Here,
that?
Has everybody got one? Oh, so
What's a Jewett brace?
Jewett brace goes around, it's like
What's the trunk like?
a turtle shell brace, it's a Jewett brace.
So I was kinda right.
Now, I think, you know what, I'm not sure it's the turtle shell, but it's a brace that keeps them in extension around the front. Let me look it up. I know it's for extension, but I'm thinking it. Oh, yeah. It keeps them in extension, but it looks like. This is a Jewett brace. people pluses, sorry.
That's what it is, though. Well, you have to decide which one, or,
Didn't you say if they require two people, it's automatically three? What? Yeah. That's good. That's good. What about like number three, we only require one person for balance? Does that make her?
You know what, I'm sorry, I was incorrect, you're right. Total assist, if you require two people, you're a one, not a two, I just told you.
Isn't that on
Right.
pretty much everything, if you require two people?
If you require two people, you're always a one. Yeah, I'm sorry, I don't know why I said that. Yeah, well, that's what we thought, but that's not what, when I heard you say that, I thought, yeah.
We're stuck on number three though.
Okay, so, oh, yeah.
Isn't that what you just said, anytime you have to use two